Anxiety disorders. They impact nearly 20 million people in America alone. In fact, they are the most common psychiatric disorders affecting both children and adults. And with the increasing stress of living in the 21st century, on both a global and personal level, this subject is getting more attention than ever. There are several anxiety disorders identified in the Diagnostic and Statistical Manual for Mental Disorders, commonly known as the DSM. Though they share a common theme of excessive, irrational fear and worry, each anxiety disorder has its own distinct features and challenges. In this program, we are going to explore acute and post-traumatic stress disorders. Vicki was coming home one evening when she was assaulted and nearly raped. She now suffers from acute stress disorder, a condition that reflects the anxiety and behavioral disturbances that develop within the first month after exposure to an extreme trauma.
Can you talk about it, Vicki? Are you comfortable talking about it?
As with all of the anxiety disorders, there are several criteria found in the DSM that establish what constitutes acute stress disorder. Much of these are shared with post-traumatic stress disorder, which will be discussed later.
What did I do to deserve this? I must have done something.
You were assaulted, Vicki. No one deserves this.
The first criteria is that the person has been exposed to a traumatic event in which both of the following were present. 1. The person experienced, witnessed, or was confronted with an event or events that involved actual or threatened death or serious injury, or a threat to the physical integrity of self or others. 2. The person's response involved intense fear, helplessness, or horror. This can come from a variety of experiences.
So you see this in soldiers who have been exposed to combat. You see this in refugees. You see this in people who have had dreadful car accidents or witnessed dreadful car accidents.
We see a lot of people who are rape victims or have gone through physical abuse or sexual abuse.
The next criterion is that either while experiencing or after experiencing the distressing event, the individual has 3 or more of the following dissociative symptoms. 1. A subjective sense of numbing, detachment, or absence of emotional responsiveness. 2. A reduction in awareness of his or her surroundings, such as being in a daze.
Do you know how you got here today?
The third symptom is called derealization, which refers to an alteration in the perception or experience of the external world so that it seems strange or unreal.
Vicki, you just don't seem like yourself. I've never seen you like this. Like what?
For example, people may seem unfamiliar or mechanical. The next is depersonalization, which is an alteration in the perception or experience of the self so that one feels detached from one's mental processes or body, as if one is an outside observer.
Maybe it's all a dream. A dream, Vicki? I mean, it feels that way. Everything about it.
The fifth symptom is dissociative amnesia.
You don't even remember pulling up to your apartment? No, I don't.
Here, one might not be able to recall an important aspect of the trauma. These are all potential symptoms of dissociation, the hallmark of acute stress disorder.
Sometimes people have no memory, they're amnesic of the event. For example, this can happen with people who have been severely abused. They may have no memory of the event, or they may dissociate when they are exposed to something that resembles that abuse.
I've seen 3 combat medics who have dissociative amnesia. They were frontline medics who had a lot of exposure to death and dying, and they have no recall for it now. They've totally suppressed it.
It's like I keep experiencing it over and over again.
The next criterion for diagnosing acute stress disorder is that the traumatic event is persistently re-experienced in at least one of the following ways: recurrent images, thoughts, dreams, illusions, flashback episodes, or a sense of reliving the experience, or distress on exposure to reminders of the traumatic event.
It's going to be a while. It's too soon. I just can't do it yet.
The next criterion is that there is a marked avoidance of stimuli that arouse recollections of the trauma.
The five senses, taste, smell, sight, hearing, and so forth, those cues can actually trigger a flashback, trigger a memory of the event, and so we actually will see victims of trauma doing everything in their power to avoid those cues.
Another criterion is that there are marked symptoms of anxiety or increased arousal. For instance, difficulty sleeping, irritability, poor concentration, hypervigilance, exaggerated startle response, and motor restlessness. The next criterion is that the disturbance causes clinically significant distress or impairment in social, occupational, or other important areas of functioning.
Yeah, I'm sorry. I know, I was supposed to send out the invoice. I'll try and get to it. Oh yeah, I'm still here.
Or impairs the individual's ability to pursue some necessary task, such as obtaining assistance or mobilizing personal resources by telling family members about the traumatic experience.
So when you have these types of symptoms, it can become incredibly difficult to work, to parent, to conduct your life. And that's the impairment in functioning that is the critical element in the diagnosis.
An important defining criterion for acute stress disorder is that the disturbance lasts for a minimum of 2 days and a maximum of 4 weeks and occur within 4 weeks of the traumatic event.
So you haven't been using alcohol or any other drugs?
No.
The final criterion states that the disturbance is not due to the direct physiological effects of a substance, or a general medical condition, is not better accounted for by brief psychotic disorder, and is not merely an exacerbation of a pre-existing Axis 1 or Axis 2 disorder. In assessing acute stress disorder, there can be many challenges. For instance, sorting out the difference between a normal reaction and a disorder.
Been having any trouble sleeping?
Yes.
That's very common.
It is?
Yes.
And during the day, it's like I can't concentrate on anything.
The normal experience of shock can take hours or days. Here, a professional is needed to assess the length, depth, and breadth of the response to see if a disorder is present. Since we're all individuals, how we cope with the recollections of a trauma depend on pre-existing strengths and vulnerabilities, as well as the actions taken or not taken at the time of the trauma.
The research indicates that the healthier that you are before the trauma, the more likely you are to have less severe reactions and symptoms to that trauma. So if you've had a whole series of traumatic events before the trauma, it might be more difficult for you to recover.
Children also have special needs. They may withdraw or chatter about everything except the event until they feel safe enough to talk about the trauma.
Now with children who are pre-verbal, this becomes more of a problem. And so what we do in therapy is some play therapy and so forth to help the child express him or herself about what has happened to them and their feelings about that.
Fortunately, there are various therapeutic tools available for acute stress disorder.
I don't know what I was thinking.
The most important thing is to listen. Trauma victims need to tell their stories, sometimes repeatedly, to get past the denial and the emotional numbness that are first used as coping mechanisms. After a trauma, ideally there is an individual or group debriefing.
A debriefing is kind of half allowing the patient to vent and talk about his or her experience and relay what's going on inside. It's half that, and it's half education, so that they have information about what they can expect.
Every person's different and every person will react to a traumatic event very differently. But so long as the person has somebody available to talk to about what happened and what that made them feel like, somebody who won't be rejecting, somebody who will listen and understand and help them through it. Whether the person actually opens up or not, just to have that person available is crucial after a traumatic event.
Because most trauma survivors don't know how trauma actually affects humans, they can be confused about their own experience.
The process of going through a trauma can be incredibly isolating, and you feel like I'm the only one that this has happened to. People come into my office saying I'm having flashbacks, I'm going crazy, and when they hear that actually that's a common response to a trauma, the sense of relief that comes from that can be real powerful.
I think some people deal with acute stress by shutting down. That what may look like pathology in some other setting, the numbing detachment, for some people may actually be how they keep from being overwhelmed.
Research has shown that hyperarousal during the first few weeks following a trauma is a risk factor for the development of the more chronic symptoms found with post-traumatic stress disorder.
Vicki, would you like to try some relaxation techniques to help you sleep? Place your hand on your chin.
Relaxation and breathing exercises, social support, psychotherapy, and medication can be useful in reducing arousal. Medications used for treating trauma-related arousal may include benzodiazepines and antiadrenergic agents.
How are the medications working right now?
I think they're helping me sleep at night.
Because of the acute nature of the disorder, precautions are vital. If the symptoms and behavioral disturbances of the acute stress disorder persist for more than a month, and if these features are associated with functional impairment or significant distress to the sufferer, the diagnosis is changed to something else. This is called post-traumatic stress disorder.
But, they had the ground people, and that was us. We go in there and sort of clean up after.
This is Chuck. He is a veteran from the front lines of the Gulf War.
Just, body parts everywhere.
He has post-traumatic stress disorder, or PTSD.
I get flashbacks still. You ever get those?
Once referred to as shell shock or battle fatigue, this disorder was first brought to public attention by war veterans.
I had a nephew, and he was about 18. He was in the Gulf.
But PTSD can result from any number of traumatic incidents. Among those exposed to extreme trauma, about 9% develop post-traumatic stress disorder. Symptoms typically begin within 3 months following a traumatic event, although occasionally symptoms do not begin until years later.
A prime example of that is the child who is molested, who maybe at the time, right after the molest, doesn't demonstrate any symptoms. But then they hit puberty and they start becoming a sexual person, and sexuality becomes inherent to their being. Suddenly those symptoms may surface because now the sexuality that they're experiencing is inherently connected to the trauma that they experienced that hasn't been resolved for them.
Once PTSD develops, the duration of the illness varies. Some people recover within 6 months, while others may suffer much longer.
It has a profound effect because often these people, even with treatment, cannot go back to their jobs. So now we have an economic problem. It may create family and marital problems. And there's a real issue of how they're going to spend the next 25 years if they're a fairly young person in the labor market still.
There are numerous criteria that define post-traumatic stress disorder in the DSM. Most of them nearly identical to acute stress disorder, though there are some key differences. Naturally, one is duration. The symptoms must have persisted for more than 1 month.
So it's been about 12 years since you saw duty?
Yeah. And I don't understand that. I mean, that seems like a long time.
Post-traumatic stress disorder is further defined as having 3 specifiers: acute, which is under 3 months duration, chronic, greater than 3 months, and delayed onset, where symptoms began at least 6 months after exposure to the trauma.
Yeah, I'm not going to be able to come in today.
PTSD may affect people's physical health and immune systems, and behaviorally, it tends to be associated with problems with self-regulation and impulse control.
It's not like you're giving me any decent hours here, right? I'm part-time, remember? Right. That's right.
Many continue to lead traumatized and traumatizing lives.
The divorce rate for the combat veterans I work with is extremely high, 3 and 4 marriages. Okay, their employment stability is another factor. Many of these men have had 50 jobs since they were in the military, being fired or walking off jobs because of conflicts with authority figures.
In the general population, the one-year prevalence of PTSD is about 3.5%, with women having almost twice the prevalence of men. The disorder may develop at any age, including childhood. The highest rates of post-traumatic stress disorder are found among women who are victims of crime, especially rape, as well as among torture and concentration camp survivors.
I just can't get over the dreams, the images.
8 months after being assaulted, Vicky struggles with her stress. People who develop PTSD become stuck on the trauma, reliving it in thoughts, feelings, actions, or images.
No, not tonight. I'm tired. I think I'm gonna just stay home.
Once this occurs, they start organizing their lives around avoiding having these feelings or sensations.
And when things are not contained in that way, they tend to get over-aroused, irritable, angry, emotional.
We'll see people who are sex abuse victims avoid relationships entirely because they don't want to touch upon the issue of sexuality. It becomes so painful for them. On the opposite extreme, sometimes we see people reacting in the other direction. They become incredibly promiscuous.
About half of all cases of PTSD remit within 6 months. For the remainder, the disorder typically persists for years and can dominate one's life. A chronic sense of helplessness, physiological hyperarousal, and other trauma-related changes may permanently change how a person deals with stress, alter his or her self-concept, and interfere with the view of the world as a manageable place. In fact, a longitudinal study of Vietnam veterans found 15% of veterans to be suffering from post-traumatic stress disorder 19 years after combat exposure.
It's hard to corroborate, but one figure that has been put out there in the veterans community is that twice as many veterans have committed suicide as were killed in combat since the Vietnam conflict.
There are also what are called secondary symptoms.
People can become severely depressed because their life becomes restricted, or they can't perform their job anymore because of their trauma.
Suddenly we might have some other disorders now. We might have a depression going on, substance abuse problems. So there can be secondary symptoms that arise out of an untreated trauma that can complicate the matter.
Like acute stress disorder, how serious the symptoms and problems are depends on many factors, including the intensity of the incident, one's unique coping ability and support system, and other factors.
We have found that people with more social support typically will have less severe PTSD. Not always, but there is a greater likelihood they will have less severe PTSD, or their acute stress reaction does not go on to develop PTSD.
I tell you, man, my boss, you know, it's like I'm trying to stay
By
away.
virtue of the more sustained nature of post-traumatic stress disorder, a number of changes are typically observed, including decreased self-esteem, loss of sustained beliefs about people or society, hopelessness, a sense of being permanently damaged, and difficulties in previously established relationships. Trauma survivors may turn to drugs or alcohol to make them feel better, and turn away from friends and family who don't seem to understand.
I don't understand my own brother's behavior anymore.
The entire family is profoundly affected when any family member suffers post-traumatic stress disorder.
I feel like Chuck and I can't even communicate. Yeah, well, yeah, sure, of course it's upsetting.
There's a real sense of helplessness. What am I supposed to do for this person? How do I act? Sometimes people withdraw because they don't know the right thing to do, which can be disruptive to any relationship when somebody withdraws. Other times the person and the family might try to help when the help's not really the thing that the victim is seeking. What I talk to victims about is educating the people around you about what you need, because people won't know. People can't read your mind. And when I work with families, I work with them on asking the victim, what is it that you need? How can I help you?
Fortunately, there are a number of treatment approaches for dealing with post-traumatic stress disorder.
I just don't know how to deal with those kinds of thoughts, you know.
Cognitive behavior therapy can be helpful through teaching learning skills for coping with anxiety.
Something I would like to do would be to try to explore those chain of thoughts.
A therapist may focus on dealing with negative thoughts through what's called cognitive restructuring or focus on anger management.
There's nobody around. There's just a lot of dead bodies. And
Exposure therapy is one form of cognitive behavioral therapy unique to trauma treatment, which uses careful, repeated, detailed imaging of the trauma in a safe, controlled context to help the survivor face and gain control of the fear and distress that was overwhelming in the trauma.
The treatment for PTSD is kind of come full circle, and the most popular treatment today is exposure therapy. Actually having people talk about their trauma, if you will, experience it again, put some feelings to the events that happened to them in an effort to find some emotional closure for it. The bad memories might not ever completely go away, but they're not as emotionally charged each time you talk about them.
Also, preparing for stress reactions called stress inoculation, as well as addressing urges to use alcohol or drugs when they occur, are important to the treatment process.
So how about the drinking?
Well, I'm trying to cut back on the drinking.
Have you reconsidered getting back into AA?
As are communicating and relating effectively with other people. In fact, group therapy can be a very effective tool.
Groups are highly effective because you're putting people together with common symptoms and often common traumas, such as combat veterans or rape victims. And what goes on in that process is that you learn that what someone else has gone through, you're going through, and your reaction to that trauma is not abnormal.
Medication can also play an important role in treatment, helping to reduce the anxiety, depression, and insomnia often experienced with PTSD.
Are you having any side effects with the medications?
There's some, a little drowsy, although I'm sleeping better, so that's good.
In general, therapy is crucial to breaking the pattern of self-defeat by re-examining the traumatic event and the patient's response to it. Education about the disorder and recognition of cues or situations that trigger symptoms can assist clients in moving on. And research is yielding new and promising therapies and approaches that can help those with these disorders lead more productive and fulfilling lives.